the Global Learning Center is a non-profit that was started in 1988 with the mission of educating people around about issues around the globe, not just locally, but with a global perspective. And so to that end, we've been organizing approximately monthly presentations, at least from August to May. We also celebrate the United Nations anniversary every October. So it's just a nice organization with a mission to educate. So that's what we are doing.
All right.
So if you are not on our email list yet, please contact us, join us. We are currently meeting by Zoom during the pandemic. Hopefully, sometime soon we can have in-person meetings again, depending on how the pandemic develops. Usually when we were meeting in person, that was, we had a dinner at some local restaurant and then had the presentation in person at that venue.
Okay. Okay, we'll get started here. We have our program tonight is titled COVID-19 Pandemic Exposes Fatal Health Inequities. And we have two speakers. One is Dr. Meredeth Turshen, who is a professor emeritus from Rutgers University. She has written a number of books on world health. She's also did some books on health services in Africa. And she's going to speak on how this COVID-19 has affected the distribution and the distribution of health services, not only in the United States, but throughout the world. And then the second speaker is Annie Thébaud-Mony, who is with the French Institute of Health, and Meredith will introduce her. Both Meredith and Annie have collaborated on research together. I think they've translated each other's books in French and English, I believe. And so now I'd like to turn it over to Dr. Turshen.
Thank you. So I'm going to bring up my slideshow.
Okay.
Can you all see this?
No, not yet. I think you have to first share your screen and then bring up your presentation. Now we can see
Here we go.
your desktop.
Here we go.
We are good.
Well, that's the flyer.
Okay.
Yeah. That's the first one.
So this is our introduction, what has appeared on the flyer. So I'm hoping you're familiar with it. I'm going to give a longer introduction to Annie Thébaud-Mony. She's a longtime friend and collaborator. She sent me these slides. It's the middle of the night in Paris where she lives, so she's not joining us tonight in this presentation, but she wanted you to know that she's been a public health researcher for 40 years. She's worked in Africa and in South America, as well as in France. And I first met her in the United States when she was working on her doctoral dissertation. She then went back to France and started working on local problems, beginning with tuberculosis among immigrants and moving on to issues of family planning, which I collaborated with her on when I was in France for a year working with her. she feels that from this experience, she's really learned a lot about what are the problems of public health and especially infectious diseases and how public health handles them as opposed to the medical approach. And when we have spoken about this, and we've been meeting both in person before the pandemic and of course, continuing online in email correspondence, we very much think alike on these issues, and it's enabled us to collaborate and to publish together for a number of years. And we've published widely, both in the United States and in France and in other countries. She sent me some slides just to give you an idea of what the issues are. And in France, she wanted you to know that France has been hit very, very hard by this pandemic. One of the most hard hit in the European areas, but also ranking quite high in the world in terms of numbers of cases. Overall mortality has really shown a tremendous increase of over 9%. She wanted to particularly point out that the foreign-born population, they don't keep statistics by race or ethnicity in France. So one has to look at the foreign-born population, which is actually an underestimate because there are many in the second and third generation who should be counted in this immigrant population. Those coming from sub-Saharan Africa, mainly from former French colonies of West Africa, have really been hit the hardest. They occupy the lowest kinds of jobs in terms of menial work. And also people coming from North Africa, again, former French colonies, have also been hit very hard. And the area where many of them live near Paris is called Seine-Saint-Denis. And what's striking is that the mortality is before the age of 65. So this is not particularly hitting the elderly. Many people don't live that long, but you've seen a 70% increase in people under the age of 65. This is a district that Annie knows extremely well. She's done a lot of studies there, including the one on tuberculosis and the one we did together on family planning. Just to give you a map to show you where this area is and how widely spread out it is, you can see that Paris is quite small and compared to this area of Seine-Saint-Denis. And it is mainly an immigrant population that's living there in very, very difficult circumstances. Annie and I have talked a lot about how public health systems have been destroyed by the privatization of healthcare and the emphasis on medical care. And she's given me some data on the closure of hospital beds, and particularly on the elimination of personnel. This is a reduction in force of the people who work in the public service and in private healthcare in France. Overall, the epidemic has caused more than 100,000 deaths in France and over 5.3 million cases of infection. And this is in a population of just over 65 million. France actually rates very high in numbers of cases of infections. It's fourth behind the United States, India, and Brazil. So COVID inequalities have really widened in France as a result of this pandemic. Annie's current work has been on people who've been affected and harmed by their work environment. She's been looking particularly at the effects of cancer that is associated with work environment. And she has created this association, Henri Pézra, for work, health, and environment, which brings together people from all over France who have tried to bring collective complaints and lawsuits against employers and against the government for the kinds of work and conditions they encounter. I've been working at Rutgers University for over 35 years. I retired last year, or sorry, I retired in 2019. And We continue to work together as on this article that appeared in the monthly review. So a long friendship.
I'm ready if you are.
Oh, well, I'm at the Global Learning Center meeting right now.
I'm sorry?
Didn't hear.
Please continue. Somebody's microphone was unmuted.
Okay, thank you. So I'd like to give you an overview of our presentation this evening. We have written this together as we do most of our work. I'd like to start with the question, and these were questions that were suggested by Jim Phillips, to whom I'm extremely grateful for the opportunity to give this presentation and for his ideas about what would be most interesting to you that appeared in our monthly review article. So we'd like to start with the question of the commodification of health services and how they undermine the right to health. I'm going to spend a lot of time on the definitions of these terms, which I consider extreme jargon used by economists. And then I would like to move on to specifically how these things have affected the pandemic of COVID. In the fourth section, I'll look specifically at health inequities, adding to them not just the health services, but problems with water supplies and problems with food scarcity, both in the United States and around the world. And then finally, I'd like to add a new section that didn't appear in our article because it was written before the vaccine was available, but I would like to talk about the impact of these trends of privatization, commercialization, and financialization on the availability of vaccines for the world. So part one, the right to health. I'd like to discuss this because it's not universally accepted that there is a right to health. It first appeared in the Universal Declaration of Human Rights, which some of you may know. Our own Madam wife of President Roosevelt, Eleanor Roosevelt, was responsible for pushing the Universal Declaration of Human Rights through the United Nations and getting it adopted. The problem is it's just a declaration, which means it has no force. It doesn't have even the weight of a treaty. But when the United Nations came to discuss the question of a treaty, it was the Cold War, and the United States and the Soviet Union could not agree on a text that was agreeable to both groups of nations. They decided on two separate treaties. One is called the International Covenant on Civil and Political Rights, which the United States signed and ratified. The second is called the International Covenant on Economic, Social, and Cultural Rights, which the United States signed but is never ratified. Ratification takes place in Congress. And it's the second treaty on economic, social, and cultural rights is the one which affirms the right to health. Among other objections to this treaty, the United States rejected the assertion that health is a human right. I'm going to show you a number of photographs of people demonstrating, because it's important to remember that the right to health is something that's defended broadly by people around the globe. The right to health maintains that access to effective health systems can generate well-being. It can help people to continue working and redistribute resources towards the poor and needy. Good health services are a force for social inclusion and democratic accountability. So this is the article in the International Covenant on Economic, Social, and Cultural Rights, which actually makes the statement about the right to health. And again, reminder that this is the one that the United States has not ratified. The difficulty with this wording is that it never actually specifies whether healthcare should be provided publicly or whether it should be provided by the private sector. It's left open. I think it's interesting to think about what were the issues in 1966 the question of the stillbirth rate and infant mortality. Infant mortality is still a huge issue in the United States, especially comparing the United States to other countries in the world. We are very far down among the developed countries in our ability to cope with infant mortality, but we don't talk so much about the stillbirth rate. At the same time that the UN adopted the Universal Declaration of Human Rights, the World Health Organization was formed and created a constitution, which was the document that all new members had to sign and adhere to. Remember, in 1948, a lot of Africa and Asia was still in colonial hands, and there were not so many independent countries. So this was signed by about 60 some odd countries, as opposed to the 194 now that are members of the United Nations. The WHO Constitution requires all members to agree to these statements and to incorporate them as far as possible into their own legislation. I think that it's contradictory with the position the United States took later on rejecting the right to health as a human right. Something that Annie and I have been writing about and feel very strongly about is a meeting that was held in 1978 in Alma-Ata, which is part of the then Soviet Union, right on the border with China, where UNICEF and the United Nations, that's the United Nations Children's Fund, and the World Health Organization got together with their members to discuss the question of primary health care. And they adopted this very strong declaration that affirms health as a human right. It went far beyond health as just medical care, because it promised access to health care as part of a new international economic order, which would give sovereignty to the new third world countries. And it required governments to provide universally accessible primary health care. So it made it a government provision as a statement of who should be responsible for providing healthcare to their nation's people. And of course, it had a very strong condemnation of what it regarded as a gross inequality looking around the world. And as soon as it was published, there was this enormous backlash from countries which had very strong private healthcare sectors like the United States. It actually, the United States has always been very strong at the World Bank, and it actually pushed the World Bank to create a health unit for the first time in what was then its 35-year history, in order to push loans for the privatization of health services. From 1981, when the Republican Party was in control of the Senate, and remember, that's the party that ratifies treaties, the United States opposed the World Health Organization for supporting what it regarded as socialized medicine. The United States promptly cut its contribution to WHO, something which will be familiar to you from the former Trump administration. And it started what has become really a massive shift of funds from the regular WHO budget based on membership dues to what is now 80% of the budget based on voluntary contributions. And the problem there is that voluntary contributions are controlled by the donors and not by the democratically elected members of the regional structures, and WHO is a very regionalized structure of the organization. And by the way, I worked for both UNICEF and the World Health Organization. I worked in Geneva for WHO, particularly in the maternal and child health and family planning unit. It wasn't until the year 2000 that WHO finally adopted something that was as strong as a rights-based approach to health as a policy that would dominate the organization's budget and commitments. And it based it on a general comment that was adopted at the United Nations in its Economic, Social, and Cultural Rights Committee. Again, this was not a legally binding document. It's just like a declaration. And these general comments generally interpret human rights that are enshrined in the UN conventions. Once again, this WHO policy is not as radical as the Declaration of the Alma-Ata meeting. It does not specifically recognize that healthcare should be provided by governments. So I'd like to turn now to this question of how do speculative investment and commodification of health services undermine the recognition of the right to health as a human right. So I'm going to go through these definitions, this economic jargon. And for each of these, I will be giving you both general examples and health-specific examples to really make them clear. So privatization is really the conversion of public to private goods. Commercialization is the marketization of those goods. And financialization really is about the private equity industry. Private equity is really having a boom because interest rates are so low, which means that borrowing money is cheap. It allows them to buy companies. And what they do is they buy these companies and they strip them of their assets. They load them with debt. And in an attempt to sort of consolidate and cut expenses, they fire a lot of workers. So a lot of people lose their jobs. The interest of private equity is not to invest in companies. This is very short term. In effect, it bankrupts many of them. Its model is to buy and sell companies. The best example I could find of privatization of national assets comes from the United Kingdom. Started in the late 1970s when Margaret Thatcher became the Prime Minister of Great Britain. So here's a list of some of the national assets that were privatized. You all know BP. It's now wholly private, but the partial sale started in '79. And the list goes on. The problem was that created a deep recession, mass unemployment, and soaring inflation. It substantially increased socioeconomic and health inequities in Britain. And Thatcher's public sector reforms applied business principles to the welfare state. And in effect, it prepared what has become the massive privatization of the National Health Services, which was sort of the pride and joy of the post-war British government. I'd like to give you now some examples within the health sector. And I've chosen for privatization the question of hospital privatization. I'd like to contrast this with public hospitals. So public hospitals are government owned and funded by governments. They operate on money that's collected from taxpayers, which means it's spread more evenly over the entire population, sick and well. And they generally have provided free medical care to indigent patients, with the government reimbursing the expenses and wages. Privatizing hospitals reduces the number of charity cases. I was really struck by the data that I found on what has happened at city hospitals that have been privatized. So my examples are Boston, which is now down to only 21% of treating patients for free. Tampa, which is now down to 10% free treatment. And Sequoia, which has reduced it to 0. They don't treat anybody for free. The other problem with privatization is the closure of many hospitals. And it's been particularly rough in rural areas where sometimes it was the only hospital around. So even emergency cases have had to be transported hundreds of miles for treatment. I'd like to turn to the second term, commercialization. And I'm giving you here 3 examples of commercialization, which are general, but from very specific fields. The first is criminal justice. And you can see how the commercial field has infiltrated what used to be a purely government concern. Second example is in education. I don't know what's happened at your schools, but at our universities, we have found that Pearson and other companies are really taking over our curricula. They've, some of the new firms that own textbook publishing are charging outrageous sums of money for textbooks, and they've also taken over testing.
Yeah.
And the third example is about research, particularly university-based research. And I'm thinking of my university, which is a state university, which means it's a public university, which is now doing research for private companies like Johnson & Johnson. Some people refer to New Jersey as the medicine chest of the nation because there are so many pharmaceutical industries based in the state. And then to give you a specific example of commercialization in the health field. When you commercialize healthcare, what you're doing, in fact, is introducing a market relationship, and you're basing it access on people's ability to pay. So you're changing over from what had been something that was taxpayer financed, publicly funded, into individually financed private care. Private care is usually financed in our country through insurance. Private insurance industry is enormous, very powerful. Has tremendous influence in legislating what our health policies should be. Worldwide, if you look at the problems of out-of-pocket payment, which is people paying for their care directly or even paying premiums for health insurance, what you find is that it's the most poverty-inducing form of financing healthcare. And this was very high in low-income countries, as high as over 41%. And it's also in our richer countries, still 20% is paid out of pocket. So this third term, financialization, I'll be honest with you, I found it the most difficult. A lot of the articles I read really refer to this as the legalized looting of US business. The rate of financialization is tremendous. When private equity takes the lead, it consolidates small producers, it loads them with debt. The new large firms have substantial market power until debt forces them into bankruptcy. By then, the private companies, the private equity firms have exited, they've sold off the companies. Companies then go into bankruptcy. In the process, they have stripped these companies of their assets. They've rewarded their shareholders. They've taken the profits to buy back their own shares because this increases their standing on Wall Street, increases owners' stake, and this increases inequality in our country. I'd like to give you an example of a company that's been financialized and bankrupted, which you might recognize. This is Toys R Us, which I think had branches in Kansas. Toys R Us was indebted to the tune of $5 billion. It was paying out more than $400 million a year just in servicing the debt it had taken on when it turned to private equity for finance. That was far more than it was spending on improving its stores. It should have been installing computer systems in order to keep up with the new online buying practices of consumers. And as a result, it became less and less able to compete in the marketplace, which is changing so rapidly. Private equity extracted over $470 million when it bought Toys R Us by collecting fees and interest. And eventually the company succumbed and declared bankruptcy. To bring it closer to healthcare, again, turning to the sectors of healthcare in which private equity is active. The first is hospitals, where they have been buying up hospitals, especially hospital chains. In 2018, their investments in healthcare was over 855 deals, 100 billion in capital invested, which is an historic high. Two large private equity firms with a 30% share of the market for outsourced emergency room doctors were at the heart of the surprise billing scandal or crisis that occurred last year. Patients who thought their insurance would cover their ER visit found instead that in ER rooms that had been outsourced, doctors could charge out-of-network rates and leave patients with huge medical bills that they were unprepared to pay for. So just to sum up this section, how this has undermined the right to health. Privatization clearly limits access to those who can afford to pay. Commercialization deprives the poor of free health services like immunization. And financialization results in fewer facilities and higher profits for the equity firms. These three trends of privatization, commercialization, and financialization are closely intertwined. Commercialization can be thought of as a framework for analyzing the intersecting processes of private sector expansion, market liberalization, and privatization of state assets. The marketplace is inconsistent with the healthcare sector, aims and goals. Markets assume perfect competition, which presupposes more than one provider, even when in reality there's only one available. Markets also assume symmetrical information, which exists when buyers and sellers are equally well informed. But we know in reality that a person with little medical education cannot second guess a heart surgeon in deciding whether an operation is necessary, and if it is, whether it should be a heart transplant, should it be a bypass, would a stent do? How do I know? There's no way I can know such things. So again, I wanted to stress the amount of activism for equitable healthcare, not just in the United States, but ongoing worldwide. I could name some leading groups. One is the People's Health Movement, which is based in India. It's a global network of grassroots health activists, civil society organizations, and academic institutions. And it has members in 70 countries. Another is MedAct, which is based in the UK. It supports professionals working for the universal right to health. And a third that I might cite is Health Action International, which is based in the Netherlands. It advocates policies that enable access to safe, effective, affordable, and quality assured medicines and the rational use of medicines. In activism, street demonstrations are common, but also as advocacy with policymakers. So turning to section 3, how do privatization, commercialization, and financialization affect healthcare delivery in the COVID-19 pandemic? The COVID pandemic is a public health crisis, as we all know. And we have a very clear thesis about this, that it has exposed inequities in our current approaches to health and healthcare. In this section, what we'd like to do is to illustrate how each of these three processes of privatization, commercialization, and financialization has perverted the universal right to human health and the goals of health for all, enunciated in the Alma-Ata Declaration. So first of all, what we have noticed is that instead of a public health approach, the first thing that happened was that tertiary care, meaning hospital care of the highest level, was taking the lead. And in contrast, we believe that the public health response should be at the primary care level, where health education and prevention can be adapted to local conditions in the community. It was interesting to hear you say that one of you was working with the Indian community, and I'll come to some data later about how the American Indian community has been highly affected by this. But the idea that adaptation to the local community is something that is so important in an ethnic community like the American Indian community means that primary healthcare should have taken the lead in this epidemic. Instead of what we got was acute patients filling ICU beds, a scramble for ventilators, beginning at the end of the process instead of beginning at the beginning of it, the start of it. Of course, being a mainly privatized health system, this happened because it's more profitable than primary health care is. Commercialization, I wanted to give you an example that's very current. That happened under the Trump administration. Traditionally, the Centers for Disease Control routinely collected data that planners watch closely. The number of available ICU beds, supplies of protective personal equipment, and demographic information on how many cases are suspected and how many are confirmed. The data are used to track the pandemic and make crucial decisions about when and where to lock down and how to allocate scarce supplies. When asked about the switch to the commercial firm teletracking technologies, the Department of Health and Human Services officials said, "Oh, it's necessary. We have to speed up reporting. We have to improve accuracy." But critics pointed out that that's not what happened. What happened was that it created chaos. That this was a company that was known for offering asset and patient cost control and management that had never done anything in health monitoring. And it led to the suppression of data that would have revealed the real state of affairs. And we know how that has set back the whole handling of the pandemic in the United States. And again, an example from financialization. It really has shown up the mass market failure. It has aggravated the weaknesses in private medical sectors everywhere. Dependence on private providers is now a global problem, a consequence of the neglect of national health systems, often as a result of conditions for loans that were imposed by the World Bank. Remember, back in 1980, they opened up their health unit. They wanted to push privatization of healthcare, and part of that was to offer loans to do so. But then they began saying that any loan for any problem, you had to also privatize your national assets, and you had to adopt certain conditions, including in your health sector, that it should be put into the private sector and reduce your government spending on health care. So I'll turn now to the fourth section of what has been happening in these other sectors like water and food. But I'm going to begin with the health sector, and I wanted to come back to this question of how the health inequities among our different population sectors have been shown up in this pandemic. I'd like to stress that it's racism, not race, not ethnicity, and not comorbidities. Racism drives inequity across the COVID-19 continuum. Structural racism exists because discriminatory practices in one sector reinforce parallel codes in other sectors. This creates interconnected systems that embed inequities in laws and practices and policies. Consequently, education, employment, housing, credit markets, healthcare, and the justice system mutually reinforce practices that allow or encourage discriminatory beliefs, stereotypes, and unequal distribution of resources. And here are the data to back up these assertions. These are data from the beginning of this year, and they show how much higher rates of death from COVID, much higher rates of cases, much higher rates of hospitalization in each of the groups that are named here, beginning with Native Americans, continuing with the Asian population, looking then at the African American, non-Hispanic population, and finally at the Hispanic or Latinx. I was shocked by this data, frankly. I had not realized it was as high as it is. I had heard it twice as high, but some of these are nearing 4 times. I mean, 3.7 times as high for the Native American population is really shocking. So I just wanted to run down these reasons for these disparities, beginning with racism, which has a history of inequitable access to healthcare and unequal treatment by health providers. Looking next at the question of income inequality in this country and the higher job loss rate among ethnic groups, minority groups. The greater exposure to the virus, because these are people who work in essential jobs, and they are exposed both at work, getting to and from work, and in their living conditions, which are often more crowded and multi-generational. So I'd like to turn now to this question of water. And it's something that I added, particularly at the request of some of my colleagues who said, you know, access to clean water is what has made the major changes in health worldwide. Clean water has changed everything since the 19th century in England and the discoveries of how waterborne diseases were a cause of so much illness. The problem is that water availability is very much threatened now by both the privatization of water supplies.
People can't wash their hands with water and soap. at home.
Exactly.
3 billion.
But the data on what the differences between poor and rich households on who can wash their hands is really extraordinary. So 20% of poor homes can do it, people living in poor homes, but 80% of the wealthy, even in Africa and Asia, have access to hand washing at home. So it's great advice if you can take it, but it isn't great advice if you don't have the facilities to do it. One of the problems has been that it's mostly women and girls who have to walk to long, far distance places for sources of water and carry that on their heads to bring it back home for the family, and have encountered all kinds of problems walking to and from these water sources, including being attacked. So the right to water is something that Maud Barlow in Canada has been working on for years. If any of you can get access to her film, which is called Blue Gold, it's absolutely wonderful in describing what the problems of the right to water are and how she is proposing a UN convention to specifically say that water is a human right. I think most of us became acutely aware of the problems of dirty water when we became aware of the Flint, Michigan crisis, when lead contaminated water threatened child health. The issue emerged again during the pandemic last winter, when several storms worsened by climate change exposed regulatory failures. Blackouts in Texas, Louisiana, and Mississippi showed how the power supply companies control water supplies. Water provision, of course, depends upon pumps and pressure supplied by energy. The Texas electric grid, for example, relied on lightly regulated natural gas, a system that completely disintegrated in the extreme cold for which it had never prepared. And by the way, there's currently a bill in Congress called Water Affordability, Equity, and Reliability, and it's meant to reinvigorate our public water systems and advance water justice. However, water has been highly privatized and financialized on a global basis. And again, this is the World Bank who has pushed this, what they consider cost recovery programs. In other words, nothing should be given out free. You should pay for water. And they don't distinguish between whether you're an individual residential water user or a major multinational agribusiness company, and agribusiness is the greatest water consumer in the planet. Several countries have really pushed back against this. In Bolivia, the city of Cochabamba launched a series of very successful protests in the spring of 2000, when the World Bank threatened to privatize its municipal water supply. In 2016, the Indian city of Nagpur had a protest because it saw that this pilot scheme in their city was going to be the prototype for the whole nation and threaten water supplies in all Indian cities. In 2019, in South Africa, a coalition against water privatization mobilized poor communities to oppose that system's takeover by private companies. There is a new trend, which is called the remunicipalization of water. So cities are trying to take back water control from private companies. I recently learned that my own private company, Suez, my company in the sense of it actually runs the water system in my town where I live, is being acquired by Veolia, which is one of the largest French water companies in the world. It's a French company and it's one of the largest private companies in the world. It is highly financialized and it's threatening to merge with Suez, which will be a disaster for consumers. So turning now to food scarcity. I'm sure you all remember the time of empty food shelves in your stores. It's another huge topic. I can't really do it justice. I'm just going to summarize a few problems. From field to consumer, the COVID-19 pandemic has affected food supplies. Food production, food processing, food distribution, and the demand for food are all altered by COVID-imposed constraints. COVID lockdowns affect worker mobility, changes in consumer demand, closure of food production facilities, closure of hotels, restaurants, and schools, restrictive food trade policies, and financial pressures in food supply chains. We're hoping, of course, that these data on what's going to happen in the United States will be changed by the new Biden administration policies of both cutting child poverty and giving out stimulus bonuses for people. This is a slide that just shows you what are the major components of the dynamics of what threatens the food security and nutrition. And I blew it up so that you could read it more easily. But in the next slide, I'm going to show you what the dynamics are. Just so many of them that it's sort of hard to read. But this is the arrows show you, and some of the arrows are in both directions, but they show you that disrupted food supplies via lockdown policies relate to global economic recession, disturbs food supply chains, and broken social protections. But in turn, global economic recession connects to uneven food price effects, changes in production, and altered food environments. The end result is increased poverty and food insecurity. I'd like to give you one example that I know from, I did a study of the Congo 5 years ago, and this is research that was reported by the Human Rights Watch. In the poorest parts of Kinshasa, which is the capital of the Democratic Republic of Congo, where the extremely poor live on 72 cents a day, adults eat meals once a day, every other day, and children eat one meal on alternate days. That single meal is usually served at night when enough money has been earned that day to buy the ingredients. If you put that situation into 2020 or 2021, when lockdowns have made it impossible to go out and earn enough money to feed a family, you can see how starvation would set in. So how has the food supply chain been financialized? Well, private equity has taken a tremendous interest in the food and beverage industry. And food supply chains, like the chains for personal protective equipment, are subject to offshoring and the extractive policies of private equity. From 2018 to March 2020, private equity firms acquired 350 nutrition companies, food and nutrition companies in the United States and Canada. The crisis has pushed some supply chains to the brink of bankruptcy, attracting even more investment from private equity. So one example is the disruption of grocery store chains in the United States. From 2015 to 2018, 7 major grocery chains employing more than 125,000 workers filed for bankruptcy. Behind all 7 bankruptcies are private equity owners, which have extracted millions from grocery stores, funds that could have been used to upgrade stores, enhance products and services, and invest in employee training and higher wages. When the COVID crisis disrupted food supply chains, grocery stores could not restock fast enough to meet demand, while bulk shipments destined for hotels, schools, and restaurants rotted away. So this is the final section of this presentation about global vaccine availability. We see here the same patterns of the impact of privatization, commercialization, and financialization play out. From public sector drug research based mainly in universities to offshoring of production The pharmaceutical industry has gone through all three stages of privatization, commercialization, and financialization. Many large financialized pharmaceutical firms, including Johnson & Johnson and Pfizer, use their profits not for drug innovation as they claim, but to distribute higher dividends to shareholders and to buy back stocks to increase their stock market value. Some drug companies like AstraZeneca have pledged to provide their vaccines on a not-for-profit basis until the pandemic comes to an end. Moderna and Pfizer are charging currently $30 to $39 for two-dose shots. Governments have ordered about 780 million doses. The United States has ordered 200 million at the cost of 3.9 billion. The European Union has commissioned 300 million doses, leaving only 40 million doses for the lower income countries via the COVAX facility managed by the World Health Organization. COVAX acts as a platform to support the research, development, and manufacture of vaccines, negotiate their pricing, and arrange for equal access for countries. That's the theory, not the practice. This is a map of the distribution of vaccines worldwide. The latest data I could get was the 30th of March, 2021. 86% of shots administered have gone to the high and upper middle income countries, and 0.2% have been administered in low income countries. Just one example of why shortages are occurring. India is a major vaccine producing country, but it has stopped exports because of the rising number of cases at home. As a result, neighboring Nepal, which was dependent upon Indian vaccines, has experienced a shortage and has actually halted its vaccination campaign. Some people are calling this global vaccine apartheid. The World Bank has promised to come to the rescue, rolling out a $12 billion program, but the program does not ensure free access to healthcare. It doesn't address the key challenges. And the particular problem is with the World Trade Organization, which is currently meeting to discuss a so-called third way of how to give access to the intellectual property or the patents for these drugs so that they can be reproduced freely in third world countries which have the ability to do so. This is from Doctors Without Borders, which is one of the NGOs leading the campaign against blocking patents. So activism for COVID-19 vaccine equity is intense worldwide. An international coalition of 250 civil society groups is demanding that drug companies holding the patents make the formulas freely available so that generics can be manufactured elsewhere. Most production is concentrated in the highly developed countries, and the third way approach is to keep that concentration as it is. But in fact, there are other countries which have the capability of manufacturing these vaccines, including Argentina, Brazil, Egypt, Kenya, Mexico, Morocco, and South Africa, just to name a few. I was keen to know what is the data behind the push for making these vaccines patents freely available. And the really compelling argument is that the public investment, our taxpayer money that's behind the development of these vaccines is enormous. In total, it's over $12 billion that has been given to these companies to help them speed up the production of vaccines and encourage them to work together. In contrast, this is what's projected for their profits. So for an investment of 12 billion, the expectation is that they will receive something like 47 billion in profits. part of the argument for giving the patent, which is currently being considered by the Biden administration and being lobbied by a consortia of pharmaceutical companies, which have said, no, 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 don't do that, don't do that, is that the United States has really practically given Moderna all of its money to develop this vaccine. Patents are monopolies. They are granted to highly financialized pharmaceutical companies, and they're a clear obstacle, not only to equitable vaccine distribution worldwide, but in the long run, if there wasn't a patent system, they would make cheaper medicine available everywhere, including in the United States, of course. So that's it. I'm for vaccine equity. I hope you are too. And I'd be very happy to answer any questions that anyone has.
Thank you, Meredith. Thank you. Okay.
Bravo, thank you.
Who wants to? Well, we'll take up some questions about though Meredith's presentation. Who wants to take? Who wants to? I don't see people right now, but probably.
So if anybody wants to ask a question, please just unmute yourself. I have muted everybody during the presentation so that we wouldn't have any background noise. So please unmute yourself to ask a question or type it into the chat if you are more comfortable doing that.
Olga, maybe if you take down her central written stuff here, more people can be.
We can see who they are.
shown. But I'll just comment on how upsetting all this is. Not completely something that we're unaware of. I'm an anthropologist. I work in New Guinea and we have lots of water, but nobody else that we read about in anthropology does have. I had one student who worked in the Peace Corps in Mali, and the Peace Corps wasn't doing a darn thing for these people who had to walk miles, of course, since that's a desert area. But a German company, missionaries, was building a big pipe, and surely that would be an easy thing to do. Wichita is a sister city to a little village in El Salvador that has to wait for the water truck to come every third day and buy water because the river is completely destroyed by mining, tailings, gold mine. And it seems to me that the problem is not that everybody's so greedy, which everybody is. Bolivia, of course, had this problem too. But that governments seem to need money from people who sell what is basically public property. Now in New Guinea, they are suddenly having problems because the government, which doesn't have enough money to maintain itself in the international stage, is privatizing more or less. For 99 years, they're giving access to people who want to cut down the trees for 99 years. And nobody seems to be able to stop it.
Okay.
I'll be quiet now, but I want you to know how much I appreciate your covering this whole area. And I'm so glad you mentioned several times that there is activism, that young people are out making trouble. Nothing else will stop this, I think. And you, I'm sure you think that too, but what is your response to that? What should we do? What can we do?
Again, I recommend the film by Maud Barlow called Blue Gold, because she has lots of examples of people going out and stopping Nestle from taking over private water, public water, and privatizing it, bottling it and selling it back to people. The more we drink bottled water, the less incentive there is for public water, for people who can't afford to buy water.
Yeah.
So one of the issues is to wean ourselves off the convenience of buying bottled water and to remember to fill up our own water bottles and take them with us. The other is, I see some approval of that. The other is that we can fight for remunicipalization where our water is privatized. So even in our towns, like my town, where Suez has taken over our water, we've argued for a better contract with Suez, but we haven't been able to get back to a municipal water supply, which is what it should be. I mean, water was a public utility once, right? There's no reason why it shouldn't be again.
Right.
I think I was brought up in the days of socialist mayors in Milwaukee when they put a big filtration plant out in the middle of Lake Michigan. And I'm sure we never paid a penny for water. So it's possible.
Okay. Anyone else have a question?
Yeah,
Becky Boska?
Meredith, I love your presentation. Do you know of any countries where the spread of the vaccinations are going well without the issue of personal endeavor, personal interests, where countries are actually doing it properly? I don't want to say we're not doing it properly, but where countries are actually doing it on first come, first serve, age, then health, and those things.
Well, actually, I know of one. Bhutan, the Kingdom of Bhutan has now immunized 95% of their adults in the course of about 2 weeks.
Oh, bravo.
Tiny population.
It's a
Tiny population, not even the size of New York City. Yes, I know.
A lot of wealthy
But then Kansas only has 2.85 million people in the entire state, and we have had a terrible time.
Well, there's also a political aspect to public health, which should not exist. So
Right. I was
just wondering if you knew of where the privatization issue was not the critical issue, but the country actually reached out, like we're supposed to, I'll say, to be humanitarian equality.
Well, surprisingly, the United Kingdom, which, as I say, a lot of the national service has been privatized, but the structure, what's left in place, is very much rooted in communities. And the United Kingdom has done a fabulous job of inoculating the population. So although it has its own variant, which has created a new surge of cases, still remains very high on the list, it has done a much better job inoculating the population than any other wealthy country. So that structure of a public health service has proved invaluable. And if I had a friend who once did the calculation that if you invest in the public health, the National Health Service, a person trained and going in will give 40 years of service. So you're investing in 2 generations, in effect, if you invest in 1 generation of training people for the National Health Service. And that structure, which I have lived under because I've studied in the United Kingdom to do my doctorate, really works deeply in the community. Every single person is registered with a general practitioner. You can choose among your general practitioners. If you don't like one, you can switch to another, but you have a general practitioner in your community who looks after you and it's on a per capitation fee so that the government pays how many people are seen by each doctor. And it works.
Public health, public education, 2 cornerstones of life.
Yep.
Okay, another question? Anyone have another question here?
Yeah, I have one. So you described how the system is hampered by privatization and so on. Now, countries that want to have public health, might not interfere in other countries, but really health is good, especially with the pandemic. What happens in one part of the world impacts the health everywhere. The spread of the pandemic, everybody being immunized in Bhutan helps over there, but it still causes, you know, a P1 variant to spring up in Brazil, and who knows what next mutation. And so healthcare, much like the issue of climate change, for example, cannot really be addressed at a national level. So how can nations come together and regain some control over these affairs that really shouldn't be left to private entities? You've mentioned some of the United Nations framework, but you also mentioned essentially private entities that kind of self-constituted, that's overseeing the vaccine distribution. So how come, you know, Bill Gates is deciding where vaccines go, essentially? And how can we, I mean, in a way, your whole talk was about this, but any more comments on how nations can regain some control and how we can, you know, get back to a public health care?
So I have to say that I'm not completely impartial about this, because I worked for so long for the World Health Organization and believe in that organization. WHO is unique among the United Nations organizations in being regionalized in its structure, which means that there are 6 regions. Each region is independent, creates its own budget, its own priorities, its own health issues, and then comes together in an annual session, well, 2 actually, one in January and one in May, where people discuss how to coordinate all of this and how to organize it. WHO has taken the lead on making the vaccine available through what it calls its COVAX facility. It is undermined by Bill Gates, frankly. Bill Gates is part of the problem of why WHO has now 80% of its budget supplied by donors like Bill Gates, instead of being paid for by individual countries giving their dues as based on population and GNP. I think that rejoining the World Health Organization, as the Biden administration has done, is a first step, a very important step. Pulling out was terrible, at the most terrible time to do so. I think putting money into the COVAX vaccine and honoring the attempt of the COVAX vaccine to distribute vaccines equitably through countries, to listen to what Tedros, the Director General of WHO, is saying, would be another step. I think third, we have to pressure the Biden administration to make these vaccines like Moderna and Johnson & Johnson available. That those formulas that we have invested so much money in should not be under patent. They should be made available to other countries to manufacture and distribute to the world. I think that there is no way, there's now been right-wing pressure to turn the WHO into another Red Cross. They want to make it responding only to emergencies. That's not what the WHO is for. It was never meant to do that. It was always meant to be an organization that set health policy for the world and to coordinate world health policy. And I think that supporting that aim of WHO is extremely important.
Thank you.
I wanted to ask
Walt Chappelle.
Another question.
Yeah.
Yeah, I have a question. Can you hear me?
Yep.
Who's speaking?
Yeah, this is Walt Chappell here, Jim.
Oh, Walt Chappell. Oh, I didn't see your, I'm sorry, you're on there.
Yeah, don't have my video working, but the question is, most of these drugs are patented for, I believe, 19 years. Is that the case in this case with the Moderna and Pfizer vaccines? And if so, how do we break that monopoly? It seems to me they're making a tremendous amount of profit at $30 per shot. So I'm concerned that we have some way to make this investment of $12 billion from the taxpayers of the United States set up so that the rest of the world will actually get these patents as generic vaccines, and hopefully bring the cost down to 30 cents per vaccine. What do you think?
Oh, I think it's doable. I think that it requires putting pressure on the World Trade Organization, But the World Trade Organization is not part of the World Health, not part of the United Nations. It's not like the World Health Organization, not a United Nations specialized agency. It was created to run around the United Nations, to create a separate agency on trade, to undermine what was UNCTAD, United Nations Conference on Agriculture and Trade, which was really doing tremendous work on helping countries establish their own pharmaceutical industries and produce their own supplies of vaccine and other medication. The WTO has been able to lengthen the time that the monopoly is available under patents from what had been 17 years to now 21. And the vaccines produced by Moderna, Pfizer, and Pfizer, by the way, was supported not by not by the United States, but by Germany, but still tax money. They now can support their patents for the 21-year period. There's no cutting back on that. They will, as threatened, start to charge $139 to $150 per two-shot dose as soon as they declare the pandemic is over. I don't know who's making this declaration, but they say they know when the pandemic is over and they can start raising prices. So the way to combat that is to pressure the Biden administration to definitely agree to giving this patents, particularly starting with Moderna, which we, in effect, have paid for, that should be made available to third world countries under, it could be a compulsory licensing agreement, which means the patent holder doesn't have to agree that the license will be given. It just has to be a public health emergency declared, and that then it will be given to another country to produce that vaccine or to import it at generic prices.
So when that agreement was made with Moderna, was there anything in the contract that said that that 12 billion from the United States is going to actually mean that that is going to be administered at a reasonable price? I'm saying $30 a shot, 30 cents per shot as opposed to $30.
Do you really think the Trump administration would do that? No.
Was it in the contract is the question. I don't know.
Now the contract does not say that.
Is the Pope still Catholic? Last I checked, he was. That was my sarcasm for the day. Sorry.
No, that's not in the contract. The contract.
So is there any way to get these vaccines out to the rest of the world without hoping
that there is a
economy bankrupt?
But there is this clause in the World Trade Organization called the TRIPS agreement, which was negotiated because of the AIDS epidemic. And in that agreement, there is this arrangement for compulsory licensing, which says that you don't need the patent holder's agreement to give the patent to a country in a public health emergency. This pandemic is a public health emergency. The United States government should give that patent in Moderna vaccine, which we paid for, to COVAX, which is a pooling facility for the patents for vaccines so that other countries can use them.
Okay,
That's
another
what George Bush Jr. did, right? That's what he did with the AIDS vaccine. Didn't he get that dispersed to Africa by using that mechanism?
Yes, we can do that.
Beautiful. Is it going to be done? How soon will it be implemented?
Well, the COVAX has existed since last year, when the whole notion of putting money in to create a vaccine first came up. The problem is that so little money has gone into it since then, and so few countries, none of the companies have given their vaccine formula. So none of the countries participating can actually reproduce the vaccine. The pressure has to be brought to bear on those companies to give the formulation of vaccines into the COVAX facility so that WHO can be in charge of distributing those vaccines and distributing the formula for the production of those vaccines to countries in need.
Is Johnson & Johnson and AstraZeneca under any obligation to reveal how they have developed and let India or Kenya or South Africa develop and produce?
The AstraZeneca vaccine has been produced with India. Money was given to the India Serum Institute, if I'm not mistaken. And India has tremendous capacity to produce vaccines, as one of the leading vaccine producers in the world. So, and India for a long time refused to acknowledge the international patent system. But when it joined the World Trade Organization, it had to sign a contract saying that within a period of 12 years, it would acknowledge patents, and they do now. So although it could produce the vaccine on a generic basis very cheaply, it is not doing so. It did so with AIDS vaccine, not with vaccines, but AIDS treatment. There is no vaccine for AIDS, but there is treatment. And the treatments were made available in generic formulation, which cut the price from $12,000 a year in the United States to $100 a year produced by India and distributed in Africa. Dramatic, dramatic. Could be done with our vaccines for COVID as well.
Okay, another question?
What's it take to get that done?
As I say, it's pressure from public. It's all these street demonstrations. It's all these groups that I mentioned to you. You can join any of these international groups. They're wonderful. Create chapters in your own community. Bring pressure to bear. It's the only
You
thing.
have to waive it. Wait a minute. Any other questions here? Okay, I wanted to ask you, Meredith, about the how privatization, commercialization, financialization has affected the availability of treatment for COVID, the treatment methods.
Well, that's a really interesting question. You know, the National Institutes of Health has the capacity to actually develop treatments and to not only the Food and Drug Administration review treatments, but the National Institutes of Health have laboratories in which treatment can be developed. Also, they can contract with universities. They have a tremendous number of contractual arrangements with universities to develop treatments. And in fact, Rutgers University has been doing a lot on developing new kinds of tests and has developed some new treatments that can be done in the public sector. The problem is the private sector, being given so much money, found it very profitable to start experimenting with all kinds of treatments. And some of them have been cast aside now, as we know, hydroxychloroquine.
When I press that line, then I have a microphone.
Wait a minute, Father Stephen.
Oh, you can. Okay, good.
Go ahead.
Hello?
So I think that that the private sector has really taken the lead on this because they see it as a very profitable aspect of their businesses to provide new treatments for this new disease. And remember, COVID is not just a disease, it's like AIDS in the sense that it's a syndrome. It's really such a collection of such varied illnesses that result from this virus. The numbers of treatments that can be developed, the numbers of areas, whether it's for heart or for lungs, for respiratory conditions, for skin, I mean, it's really enormous, the number of problems that arise as a result of, and we haven't seen the end of it because we don't even know what some of the long-term effects of this disease are. So, you know, the private sector will continue to find this a very profitable area for advancement of producing medications. And of course, the United States pays the highest for it because the United States has no control. We don't do any Medicaid work on limiting the prices that we pay for these drugs under Medicare or Medicaid. We could have signed contracts with the pharmaceutical industry. The National Health Service in the UK has this kind of contract. It pays much lower prices. It negotiates them on a group basis. But this is not done in the United States, which is given free rein to the companies to charge what they will. And you all know that treatments, for example, for diabetes have just escalated enormously in the last couple of years with no change in the actual formulation of the treatment.
Yeah. Father Stephen, did you have a comment?
Yeah, I have a question. This is a little bit directly off the COVID problem, but it could have something to do with it down the pike. I want to know if you know of any literature or any writing that is available on that speculates whether or not water shortages due to the crisis of climate will discuss the active reason of water shortage for a war as a reason for war or armed conflict.
Yes, I do. If you give your email address to Jim Phillips and he forwards it to me, I'll be happy to send you material on this.
Oh, thank you very much.
Yeah, I'll do that. I'll do that, folks. Meredith, I wonder, what do you think we can do to protect us from future pandemics? What kind of materials do we need to protect us from the future? And some say there will be future pandemics.
Well, I think it's a really important question because first of all, you know that we had a plan in place before the Trump administration tossed it. It was one of the things that the Obama administration had prepared for the Trump administration. The Trump administration came in and said, we don't need this, tossed the plan, discontinued the unit that was in charge of this kind of planning and said, we don't need this, it's never going to be a pandemic. People foresaw this pandemic. And people foresaw that there would be future pandemics, not just of COVID, not just of coronavirus, but coronaviruses are a group that potentially will continue to expand. The first thing we can do is manufacture this stuff at home, not to be so dependent on supply chains that are controlled by other countries, not for protective equipment, not for vaccines, not for medications, not for food supplies, etc. We need to produce these things at home. We need to stockpile them. We need to have them available. We need to have a plan in place for equitable distribution across the country. And we need to have the personnel who are trained to develop these plans, administer these plans, and get these plans out to the states and to local communities. This is all perfectly possible. There are well thought out kinds of procedures for doing this kind of planning. There are programs from the World Health Organization about the steps to take in making this kind of planning. And within our own government, we have a history of being able to do this until the Trump administration tossed it. So we can go back to those and rebuild them.
Okay.
Are
Jim?
you saying going back to reality? Sorry,
Eh,
sarcasm here.
Can I make a comment?
No, Leslie. That
Okay,
was
Becky,
also
I will.
sarcasm.
As a long-term public health person, we were doing pandemic preparedness exercises 25 years ago, every year, in coordination with local and regional and state
How to
public health
contain, how to
entities.
be safe, how to do all those things. We were
Well, not
prepared.
only that, but predictive efforts and what do you do when the entire community gets seeded with some sort of pandemic virus and the hospitals collapse and so on and so forth. We've had these exercises.
Yeah.
And between 2017 and 2019, the former occupant of the White House, whose name I will not mention, basically did away with the entire CDC pandemic response team. Fired
Yes.
them all.
Yes.
And you know, the problem with public health in the United States for as many decades as I've been
There's no
alive and then
priority.
some is there's no public funding. There is not a public health entity at any level in the US that gets more than 1% of the unitary budget, whatever that is. And in Sedgwick County, the county health department gets 1/2 of 1%. So
Change your
Well,
priority.
honestly, I went up to Emmitsburg, Maryland with 75 people from Sedgwick County when I was budget director. to train for those things, poisoning and those things.
Mhm.
And we went back home with no funding. So you had pie in the sky planning, but the federal government didn't back it up.
Exactly.
Well, we can push for that too. We can push for more funding. We can push for a change of priorities. Why is
Meredith,
one?
me,
Why?
what's the most important thing you said was keep it local so that we do not rely on another area
Mhm.
for reacting to a
Mhm.
pandemic. To me, out of everything you said, after watching everything, that was the most important thing to me you said. I think that is so important.
Well, that's the essence of public health. Based on primary care, it's based on local communities, it's based on giving those communities a voice so that we know exactly what those needs are as perceived by people, and then they will participate in it and not resist it.
And you know what? Andrew Cuomo, I don't even like in New York City. But let's face it, he led New
Yeah,
Well, it's not clear that he led.
York City through wearing masks. Issues were.
yeah.
He may not be the
masks-
best person in the world, but
He did.
guess what? They had the biggest chance of spreading everything, and he stopped it. Like I said, I personally don't like him, but I think that leader is incredible.
It's not clear that he stopped it, and I'm particularly upset about the nursing home situation where he took so much money from the nursing home providers, which are highly financialized, by the way.
And he fibbed. Yeah, I know.
And then suppressed all the data about who was dying where. And something like 40% of all deaths in the United States due to COVID have occurred in nursing homes. Nursing home chains are highly financialized and are very insecure and fold easily by being in debt and then going bankrupt. And there has to be a better way to care for people. There just has to be a public way that's a better way.
We take care of ours at home.
Dr. Turshen, I thought I'd just tell you, you have two medical doctors in your audience, Dr. Leslie Page and Dr. Sarah Johnston.
Mhm.
And you mentioned whether or not we knew about privatization.
Mhm.
The university that most of us are associated with as faculty or students or staff or something is 10 blocks from the Coke Industries. And they hover over us like a fog. And they built, our last president allowed them to rent more than half the campus for 20 years. And there's been quite a fuss made, ads in the paper, and rich people have been against all this privatization. They've been allowed to select their own professor to teach correct economics. And it is terrifying. Now, Holger, who's looking away now, hello, Dr. Meyer, he's still teaching there and he's a
I'm
professor
here.
of physics. And if it weren't for Holger and Kent Rowe, don't hide Kent, there wouldn't be a single solar panel on our campus. But they put one on some kind of wheelbarrow or something and they take it around. I don't know what you do, Ken, but at least we know about these things. We know how terrible it is. We have a Democratic governor who made a mask mandate and wanted to accept Medicaid. And the Republicans said, no, sirree, Bobtail, let them die. And about 4 major small hospitals have closed. Isn't that right, Leslie? Something like that? Halstead and
Independence, Halstead, one outside south of Hayes. There are a
Hillsborough,
bunch of them.
Independence, Fort Scott,
Fort
Halstead.
Scott, that's the other one.
Yeah,
No, they've been
we-
closing because they didn't expand Medicaid. It's a
Well, yeah,
cinch.
they actually did. I used to practice in Fort Scott, so I still have ties to the community, and
No,
that
but
was
they didn't
exactly the
expand
problem.
Medicaid.
but on
They
the other
didn't.
hand,
They didn't expand Medicaid, and Fort Scott ran out of money.
Right.
And the sisters,
on the good side, they do depend a lot on religions and ethnicity here. So we have Hunter Health Clinic, which was started by the money given to the Indian, Native American, And we have.
Not in Guadalupe, Hunter Health Clinic, those, we have enough people here to support them. But like Leslie's talking about is Fort Scott. Those places, they don't have the money to support it. That's the issue right there.
What our situation is, because once she's told us so much, we might as well let her in on this. One of our African-American students in nursing was upset that there was no place for Black people to go, and she managed to get the money together, by golly, and start a clinic right in the heart of the Black neighborhood. So it's still going, and we can all go. You can pay if you have any money, and you don't have to. I guess that's what Hunter's like too, isn't it?
Well, Hunter, because it's still affiliated with the Bureau of Indian Affairs, doesn't just treat everybody.
Oh,
But
it's true. But of course,
Guadalupe will.
You can go to
Guadalupe will.
and Mayflower will, and Holy Family will. I mean, it's not that we don't have some places to go, but if you look at the hospital situation here, you know, we've got a drawing area of pretty close to 1 million people, 480,000 in Sedgwick County. We have Columbia HCA running 1/2 of our 3,200 hospital beds, roughly. And we have Ascension Health, which is a quote unquote not-for-profit religious organization running the rest. And I put that in quotes for a reason, because, you know, whether you're a publicly traded company like HCA and your need is to pay your shareholders, or whether you're penny pinching because you're a bean counter for a religious organization, doesn't make much difference in terms of rendering healthcare.
Right.
I'm glad I'm retired, people.
Well, my prayer is that after Meredith is telling us her stories, is that perhaps we can educate people further about the importance of public health, because when this started, I think we all probably reacted as that public health is not a political issue, never has been. And if you saw a few of the actually great articles in Wichita Eagle, they featured Solomon, Kansas, which was one of the first places that immediately vaccinated from the polio vaccine. And they're the ones not getting vaccinated now. So there is something about the political policies that are going on that are a little bit, well, I'm not going to speak to it because I get too frustrated. So I'm going to shut up now.
Is there any other questions anyone have?
So before we finish, I think we've had very interesting discussion, and I would like to make a recording of this event available. So I would like to ask everybody who participated in the discussion if you are comfortable with having this shared online. So if you have any objections to that, please send me an email and I will edit out any parts anybody objects to.
Thank you, Holger.
Thank you very much. And we have a long way to go. I think Meredith has pointed out the problems, the structural problems, and we have a lot of political work to do.
Yes.
On a national and international level.
Yes.
But Meredith has pointed out the problems. We need a new paradigm in analyzing the right to health care and other economic and social rights, which are human rights.
Yes.
Yes.
And that's the point. One of the points I think.
Thank you, Jim.
It's not just political rights. We understand what the political rights are from the Enlightenment, but there's economic and social rights.
Exactly.
And that's in dispute. There's a bunch of people out there who don't think that, particularly in the Republican Party.
Yep.
Yep.
But there are some Democrats that don't have trouble accepting that too.
Oh, Meredith, so you know my background is that Jim and Dottie are like my aunt and uncle. They're my family for
not a blood,
but they were my mom's best friends. So that's why you hear me call him Uncle Jim or Auntie Dotsie. That's why I do that, because we have been They're my family chosen.
We very much appreciate.
Well, we
your
appreciate
work.
your
Not
work.
just coming here tonight, but I think if you're tramping around the world, it's never easy. And thank you for doing it, and thank you for figuring it all out, and thank you for putting it.
Also, I wanted to point out that Meredith and Annie have an article on the pandemic, COVID-19, and the health, the inequalities, which is you can in Monthly Review, the November edition of Monthly Review, and you can get that if you're not subscribing, or if it's available at Watermark. But you could also Google in Meredith's name or Annie's name, and you can see it online. The article's online.
That's why I wrote down, Meredith, when you're just.
So you can read it. It's about a 10, 11-page article, right, Meredith?
Yes.
I can't wait to read it.
Yes, you can read it. You can just Google her name in and you'll find it. I tried it. So
Thank you, Meredith. And actually,
thank you very much, Meredith. We really appreciate your talk, and thank you. And thank Annie too for us, for also, we really enjoyed your talk, and we look forward to reading future articles from you. So thank you very much. And thank you for all of you for coming tonight on Zoom. We hope maybe in the fall we'll have in-person meetings again. We'll have to see.
Thank
Thank you,
all
Heather,
for the
for your work. And thanks for all of you. Thank you.
Thank
Let's give
you.
her a big hand.
Thank you.
Give Meredith a hand.
And our next program in the Global Learning Center series will be in May, and actually Leslie Page will be our presenter then. So look out for information on next month's program.
You're going to have, she's going to talk about indigenous medicine. I wanted to point out for Linda there. Linda is
No, I was just going to be
from Western Kansas. Linda is about
be a
5
smart ass
hours
and say,
here.
"Oh my goodness, Father."
Susan
Stephen, you need to
Haskell was here before. She's got off, but she's College Station, Texas. She also appeared tonight. I think
Well, I
she's
saw there was a Becky Yanyek, and is she a Czech?
Somebody we know from someplace.
That's
Becky Jennings is the treasurer of the local Democratic Party, and
But your last name is Yanyek, right?
she's ran for office. She's been she was Jim Thompson's campaign treasurer. James Thompson ran for the Congress.
I remember him doing that. But how do you pronounce your last name, Becky?
I pronounce it Genic, like photogenic, Becky Genic.
That's great. Okay, if you're Czech, you say Yanyek?
Yeah, it was a Czechoslovakian name. It was changed at the border when my ex-husband's family came over.
Well, my name is ex-husband's name, and mine would be Boschke. My main name was Alan. I'm Dutch, so you know, hey, that's how life works.
Cool.
Thank you, Meredith. I really, you had me captivated.
Thank you.
You really did. I just enjoyed every
signing
minute
off.
of listening to you.
Thank you so much. Thank you all so much. And thank Jim and Holger for assistance, because I couldn't have done it without them. Thank you.
Thank you, Meredith. We really enjoyed it.
Absolutely.
Appreciate it.
All right.
Dankjewel.
Bye.
Dag.
Okay, we'll say goodbye.
Bye.